Hello everybody. Today we are going to discuss about aerosolized antibiotics. The delivery of the medication to the lung via inhalation and the aerosolization has long been recognized as a technique to ensure high local drug concentration with minimum systemic side effects. This mode of therapy is used successfully to deliver bronchodilators and steroid to patients with asthma and COPD and is potentially compelling strategy to target antimicrobial therapy in the treatment of lower respiratory tract infection. The most successful application of this strategy to date is in the treatment of infection in patients with cystic fibrosis. It has been hypothesized that similar efficacy would be seen in patients with non-cystic fibrosis, bronchiectasis, and difficult to treat hospital-acquired infection such as ventilator-associated pneumonia. So this is the list of aerosolized antibiotics. So these are aminoglycoside, which include gentamicin, colomycin, amikacin, liposomal amikacin, neomycin, sisomycin, tobramycin. Then polymyxin, which include colistin poly B. Then glycopeptide, which include vancomycin. Then aztreonam. Then ceftazidime ticarcillin. And then ciprofloxacin. So first we will discuss about tobramycin. Tobramycin is the bactericidal aminoglycoside antibiotic with activity against the gram-negative organism. Aminoglycoside act by binding to the 30S ribosomal subunit and causing disruption of the peptide synthesis. In general, aminoglycoside antibiotics are chemically stable and have low background level of resistance and exert post-antibiotic effect. Tobramycin has particularly additional advantages. It is available in the generic form. Levels can be measured with the sensitive assay, and it has an acceptable taste of profile. Like other aminoglycoside, tobramycin does not penetrate the lungs and is not ideal for the systemic treatment unless there are no other alternative or there is high risk of antimicrobial resistance. For this reason, inhaled tobramycin was first investigated for the use in children with cystic fibrosis in 1980. Aerosolized tobramycin was shown to be effective in the treatment of chronic Pseudomonas infection in subjects with the cystic fibrosis. In 1990, the preservative-free pH adjustment formulation of tobramycin solution for inhalation was introduced to the market. Nebulization of the tobramycin solution for inhalation results in the peak sputum level 30 minutes after administration with minimal, although somewhat variable systemic absorption. Level decreases to below the in vitro minimum inhibitory concentration at 6 hours, but exert particularly long antibiotic effect as described by Lee Brion et al. In 1999. The more recently introduced tobramycin dry powder for inhalation had similar pharmacokinetic. Based on pharmacokinetic characteristic and the available evidence, aerosolized tobramycin appears to be good treatment alternative. Aminoglycoside-induced renal failure has been reported in patients with cystic fibrosis receiving aerosolized tobramycin solution for inhalation alone, suggesting that some subject will have greater systemic absorption with risk of kidney injury. Now, aztreonam. Aztreonam is the synthetic bactericidal non-monobacter with activity against the gram-negative bacteria, including Pseudomonas aeruginosa. It acts through the inhibition of cell wall synthesis and displays typical three lactam pharmacokinetics, which includes short half-life and slow penetration into bronchial secretion. Aztreonam solution for inhalation has an elimination half-life of 2 hours. Approximately 10% of delivered dose is ultimately excreted in the urine, and remainder is thought to be expectorated from the air. So colistin, next is colistin. Colistin is the bactericidal polymyxin antibiotic produced by the strain of Bacillus polymyxa subspecies colistinus and act via disruption of cell membrane of gram-negative rods, including Pseudomonas aeruginosa. More recently, the need to treat patients with the highly resistant Pseudomonas aeruginosa lung infection had led to reconsideration of its use as an aerosol. Now about ciprofloxacin and levofloxacin. Fluoroquinolone exert their antibacterial effect through the interference with deoxyribonucleic acid synthesis. These antibiotics have an activity against gram-negative bacteria, including Pseudomonas aeruginosa, as well as some gram-positive bacteria, although they do not have reliable activity against methicillin-resistant Staphylococcus aureus. In general, fluoroquinolone are characterized by the significant tissue penetration. To date, levofloxacin and ciprofloxacin have been evaluated for delivery via aerosolization in patients with cystic fibrosis, non-cystic fibrosis, bronchiectasis, and VAP. Aerosolized levofloxacin has been shown to have favorable safety and efficacy profile in phase 3 clinical trial. Earlier phase 1 and phase 2 studies showed that levofloxacin achieved high airway concentration with little systemic distribution. Similarly, aerosolized ciprofloxacin achieved high sputum concentration with prolonged half-life in phase 1 trial. Now about type of the nebulizer. There are four types of the nebulizer, that is jet nebulizer, ultrasonic nebulizer, vibrating mesh nebulizer, and meter dose nebulizer. Jet nebulizer uses the air and oxygen under pressure to generate aerosol. Ultrasonic nebulizer, it uses the piezoelectric crystal to generate aerosols. Vibrating mesh nebulizer, the drug is pumped through the vibrating mesh that creates the aerosol. The size of the droplet depends directly on the diameter of the mesh. Meter dose nebulizer, it contains the solution of the drug with propellant delivered through the atomization of the nozzles. Now, the clinical indication of aerosolized antibiotics are cystic fibrosis, non-cystic fibrosis, bronchiectasis, and ventilator-associated pneumonia. Now, adverse effect. The most common adverse effect reported with the administration of aerosolized antibiotic include cough, wheezing, hemoptysis, dyspnea, with considerable variation by antibiotic. The preparation of inhaled tobramycin that was initially studied include preservation that was irritating to the airway. The currently used FDA-approved preservative-free preparation of tobramycin solution for inhalation may cause less bronchospasm. Pre-treatment with the bronchodilator appear to mitigate this problem in patients with cystic fibrosis. Other significantly cited adverse events associated with tobramycin solution for inhalation are voice alteration and tinnitus. In pivotal trial investigating safety and efficacy of tobramycin solution for inhalation in subject with cystic fibrosis, voice alteration was usually mild to moderate in severity and improved during off drug cycle and decreased steadily in incidence with increasing tobramycin solution from inhalation exposure. Tinnitus was rare among subjects treated with the tobramycin solution for inhalation, never exceeding the frequency of 3.5%. Most episodes were transient and mild to moderate in severity. Audiology testing showed no evidence of objective hearing loss. There has also been cases reported in the literature of acute renal failure, hearing loss, and vestibular toxicity. Unfortunately, patients with the severe non-cystic fibrosis bronchiectasis seem to have worse adverse events associated with tobramycin solution for inhalation compared with the patient with cystic fibrosis. Adverse events most commonly are cough, wheezing, and dyspnea. Inhaled aztreonam is well tolerated by patients with cystic fibrosis. The most commonly reported adverse reaction is cough, which occurs in 15% of patients treated with inhaled aztreonam compared with 10% of patients treated with placebo. Thank you, guys.